Hi, everyone. I'm Brian McCourt, and on behalf of the McCourt Foundation, we'd like to welcome you to the 224 Neurologic Symposium. This is our 21st symposium, so time has really flown. But thanks to the great partners that we have, Eisai and UBS as our main sponsors, as well as Biogen, Genentech, TG Therapeutics, and MT Pharma, we've been able to continually bring this program to you all. And as you all know, our mission is striving to cure neurologic diseases while empowering others to build a healthier world. It's built off of 3 pillars, this being one, but we focus on research and helping fund research, education, and bringing some of the greatest minds directly to patients and caregivers and other people of interest. And in addition to that, our partnerships, where we use our events to partner with other like-minded foundations where they can increase their ability to be able to get their word out there, as well as raise much-needed funds for their causes. So partnerships is very, very important to us. Today, with technology now, probably one of the only good things of COVID, we now have the ability to have a much wider reach. And there's 11 countries and 25, it may say 22, but we had a few others overnight sign up, are tuning in to this educational update. So, and we're also proud to and excited to bring in Parkinson's as one of our disease states that we're able to get behind and introduce them to the educational update. Although again, we've always supported Parkinson's as one of the disease states, as well as many others, through research and our partnership program. I would like to say a special thanks to the doctors that are here. Again, some of the finest minds in Parkinson's disease and the other ones with all the neurologic diseases. And if it wasn't for them as well and all of these partnerships, we wouldn't be able to pull this event off. So thanks very much. A special thanks to Kelsey and Rosemary and Matt, our Boston team, for putting all the time and energy into this event, as well as our entire staff out in Los Angeles, who also are behind this and everything else in terms of being able to expand our whole reach and some of the new exciting areas that we've been able to now get into. And it's an exciting time to be in neurology because it is fast moving now. And what I mean by fast moving is we're at a point, I should say, where a lot of these diseases, we've found what's caused them. And not only are we working on how to stop the progression or arrest it, then work on cures. So with that, I'd like to introduce our first speaker, Barbara, Changezi. And again, it's wonderful to have both physicians here doing the presentation. Thank you so much. Barbara, all yours.
Thank you. And I'd like to, I'm looking forward to speaking with all of you today. I want to thank you for the kind introduction, particularly for calling me a fine mind. Wish my parents were here. And so what I'm going to do today, I'm Barbara Changezi. Some of you may know me. I'm over at Brigham and Women's Hospital in the neurology clinic at Hale Building. And I'm going to talk to you about the management of Parkinson's disease, which is the current strategy. And then my colleague, Dr. Albert Hung, who's sitting to my left, is going to talk about research directions, and then we'll answer questions. So thanks so much for coming. And for those of you on Zoom, welcome. Okay, so the management of Parkinson's disease. I have nothing to disclose. I am not accepting money from anyone. So Parkinson's disease, as many of you are already aware, has both motor and non-motor features. And we're all taught the very more obvious motor features, which would be slowness. The medical term for that is bradykinesia, which can manifest as shuffling, soft voice, or hypophonia, decreased blinking, small handwriting. Tremor, which is typically at rest and usually starts on one side before spreading to the other side of the body, so a unilateral resting tremor. Rigidity, which is muscle stiffness. Postural imbalance and stooped posture. With the cardinal feature, the absolute main feature that must be present being slowness. But there are also some non-motor features as well, and those can be equally, if not more so, disturbing or impairing of function. And those are playing an increasing role in the management and the tailored management to individual patients. And those include things such as constipation, depression, cognitive impairment, orthostatic hypotension, hallucinations, and active dreaming. There's more of these, but this is a short talk. We want to make sure we have time to answer questions. So this is a subset, but you get the idea that there's both motor and non-motor features. So I'm first going to go through the motor ones, and the second half will be on non-motor management. So the mainstay, before I get into the motor management, is to know that dopamine deficiency is what's leading to the motor features of Parkinsonism in large part. So I thought I would talk a little bit about anatomy. Many of you know this already, but just as a background for those of you who are new to learning about this or newly diagnosed, the basal ganglia are structures, they're nuclei deep in the brain, and there's a picture there where you can see those colored portions that are on that section of brain. And they're a set of structures that's sort of assembly line of processing the quality and initiation of movement. This is different than your coordination. This is different than your strength. Those are different areas of the brain. Having disorders in this set of structures leads to things like slowness and stiffness and tremor, while your strength is preserved. Dopaminergic neurons in the substantia nigra pars compactor, that's a fancy name, but there's a particular area of brain which is on that slide. It's the Mickey Mouse, and you can see there's some stripes along the ears of the Mickey Mouse. And that black dense area is called black substance from the Latin. But you can see that in the portion below, that stripe is much fainter, and that's taken from a patient with Parkinson's disease. And the reason that stripe is faint is because those cells have died off, and in fact, have been dying off for many years prior to the onset of the motor symptoms, because your brain has some reserve. It can compensate from some loss of these neurons, but not when it reaches a critical threshold. And that's when the motor features of Parkinsonism begin. The loss of dopamine leads to problems in this set of structures that relies on this, kind of like the oil in the engine, to work well. So a dopamine deficit leads to motor features, and one of the mainstays that we're going to have for treatment is going to be giving you the dopamine in a way that, as much as we can, mimics a physiologic state. And so the mainstay of treatment in Parkinson's disease at this time is repleting dopamine. And so how do we do this? And when patients come to my office and we have that initial conversation, I say that there's lots of ways to get at this. But the first and foremost, the gold standard of treatment for Parkinson's is levodopa. And levodopa is a building block or a precursor for making dopamine in your brain. It's something that you can take in a pill form, typically with carbidopa, to allow as much of it to get to the brain as possible and not be metabolized outside the brain. It crosses the blood-brain barrier, which is protective, only allowing certain drugs to get into the brain. And there it's converted to dopamine to replace the dopamine that a Parkinsonian brain cannot make. We have many forms available these days. We have the classic Cinemet, which is the carbidopa levodopa immediate release. We have a controlled release, which is called CR, SR, ER. We have the Rytary or IPX066, which is a capsule of beads with longer duration levodopa. There's an inhaled form, and then there's Crexont, which has just been approved. And finally, there's a Duopa intestinal infusion system, which I'm going to spend a little bit of time discussing. But all of these really are getting at this core idea of let's get dopamine to the brain. Let's give you this precursor so that the brain sees dopamine. There's a second class of drugs called dopamine agonists, and these are things that are chemically similar to dopamine, but not quite. And the analogy I give in the office is Coca-Cola versus Diet Coke. It's almost like Coca-Cola, but not quite. So dopamine agonists are drugs that don't have to be converted to dopamine, but when they're taken, they act at dopamine receptors in the brain and they mimic the effects. But they're not quite as potent and they're more prone to side effects. They do have the advantage that there are once daily forms. Sometimes the fact that they're less efficacious is useful because people with milder disease may not need levodopa and in fact may have side effects from not requiring such a strong dose. There's also a patch that be given transdermally once daily on the skin. Side effects of these are sleep attacks, orthostasis, nausea, and something called impulse control disorder, where people may start doing vice-like behaviors with short-term gains but long-term negative consequences. And that would be things like gambling, shopping excessively, eating excessively. This is a minority of patients, but definitely something that we want to advise, because if people start doing funny things like you drive by 7-Eleven and you start buying a ton of scratch-off lottery tickets, this is completely out of character for you. It really may be the drug. And that would stop if we lowered or discontinued that class of medication. There's a class of drugs called MAOIB inhibitors, and these block the metabolism of dopamine. So again, the idea is to increase the dopamine levels in the brain by giving substances that stop its breakdown. These have mild benefit, very mild, but they can work well as either initial therapy for milder symptoms or as an adjunct therapy later on, which I'll talk about in a bit. And they can be taken once daily. Selegiline has an advantage that it's broken down as part of its regular metabolism into a stimulant that can be useful for patients who are tired. Rasagiline and Xadago are also forms of this class of medication. COMT inhibitors is the final class on this slide. And these, again, block a different enzyme that breaks down dopamine with the idea of increasing dopamine levels in the brain. There's entacapone, which we've been using for many, many years. There's a newer one, which is opicapone, which is once daily formulation, and then Stalevo, which is a combination pill of levodopa plus entacapone. And this slide is showing, this is a presynaptic neuron, and the green is a postsynaptic neuron. And what this is showing is the manufacture of dopamine in the nerve that's about to talk to the receiving nerve. These are two nerves in your brain. And you can see that levodopa is being converted to dopamine. And you also see that there's those enzymes, the MAO and MAOIB, and MAOB and COMT, and those enzymes are being knocked off by some of the drugs to allow more dopamine. The dopamine are those tiny red dots that are being spilled into that space between the blue neuron and the green neuron. And we want as much of that as possible to fight your motor symptoms of the Parkinsonism. There are other therapies which work with different mechanisms, and I always think it's good to have those. I get lots of questions on those in the office. One would be amantadine or Gocovri, which is a longer-acting form of the same medication. This is actually originally an antiviral medication, but it's been shown to have some pro-dopaminergic properties, and it's what we call a dirty drug. And by that we mean it has lots of mechanisms of action. It's not really a crisp, clean one, but in this case we use it to our advantage. So it has dopaminergic effects, anticholinergic effects, NMDA antagonist. And when I say this sounds like a lot of chemistry, but each of these has different positive features. So the dopaminergic is good for your motor symptoms. The anticholinergic properties are good for treating tremor, sometimes dystonia. And NMDA receptor antagonist properties are good at treating dyskinesia. It does have side effects. It can make people who are prone to hallucinations hallucinate. It can lead to nightmares, insomnia. There's a very rare, less than 1% chance of something called corneal edema. I recommend all my patients, you should be doing this anyway, but getting annual eye exams, and at this first sign of some blurry vision, going and checking to screen for this. Of course, it could be more common things, cataract, glaucoma. It can cause some swelling in the legs. And then there's this lacy-like rash that can appear, which is called levator reticularis, but we don't necessarily have to stop the drug if we see this. Anticholinergics are a class of medication that can be used to treat Parkinsonism. They do not help slowness or stiffness, but they are used for tremor. We tend to reserve these for our younger patients because of really the adverse side effects that are commonly seen. And these, because it's anticholinergic, meaning it blocks a chemical called acetylcholine in the brain, which is associated with improving thinking, cognition, and memory, blocking it to treat tremor in Parkinson's when you give this medication can actually lead to mental dulling. And I've had patients come in on high doses of this medication, confused, struggling cognitively, and then we pulled that back and they've improved. So definitely something that we reserve for younger patients, a lot of cognitive reserve, really for specific instances of maybe they have a lot of dystonia or muscle contortion or tremor. Finally, there's this newer agent called istradefylline or Norians, which is working with a completely novel mechanism. It's an adenosine A2A receptor antagonist. And we're not quite sure how this mechanism of action is working in Parkinson's disease, but certainly trials have shown that it improves on time or time that your medications work. It seems to enhance motor function. The trials have been done with patients concurrently on levodopa. And it has side effects of dyskinesia, in other words, movements from too much medication, can also lead to hallucinations, some nausea, and rarely some impulse control disorders, both diarrhea and constipation. So here are some pearls on treatment of Parkinson's disease. Now, a question I often get when I'm in the office, I would say at least once daily by one of the patients in the clinic, and it's an intelligent one, and some of you may even be asking this tonight. A lot of folks come in saying, I don't want to start medication because I've heard that if I take medicine, it's going to worsen my disease later, or it's going to wear off, and I'm very worried about not being able to function later, and so I want to keep all my options open. I'm going to delay treatment as long as I can so that I don't get the adverse consequences of this brain exposure to levodopa. And I want to emphasize that that is actually not true. Years ago, there was a theory, reasonably postulated, that levodopa may lead to oxidative stress or damage in the brain from this metabolism of the dopamine. We no longer think this. And in fact, if you are treated adequately for your symptoms, you are more likely to be able to exercise. And exercise is the one thing thus far in our current knowledge that has been shown to slow down disease progression and also make you, at the time, feel better. And so delaying the onset of medication, leading to more immobility, lack of vigorous exercise, is actually harming you rather than helping. Also, there's a question about, do the medications lead to worsening, or do they wear off, or do they stop working? I'm going to try and explain what I mean that that's not true. We think that the disease is progressing. Unfortunately, Parkinson's disease, it's a neurodegenerative disorder, meaning it slowly progresses over time. So we don't have things to cure this, and other than exercise, we don't have things to slow it down. And so what happens when people take levodopa? The levodopa is not worsening the disease. What's happening is the disease is worsening on its own in the presence of levodopa. And so about 5 years in, somewhere around 40% of patients can have what's called fluctuations. And what that means is that the medications work, but they only work for a brief period of time. And that window of time, which I'm going to present on a subsequent slide, is going to shorten. But the medications are working. So it's not that you're somehow tiring out your brain with the exposure of these medications. It's that the disease is progressing, and that benefit of that levodopa is shorter. I hope that makes sense, and maybe we'll answer some questions at the end of the session if that's not entirely clear. I'll note that the American Academy of Neurology, that's the AAN, that's our parent organization that all neurologists, most of us belong to, and it puts out guidelines that are quite helpful based on evidence and surveys of the literature. And the AAN has a guidance on the early management of Parkinson's disease. And in fact, they have suggested that levodopa may be a very reasonable choice to use early in the disease, particularly at lower doses, less than 400 milligrams daily. Our goal is to treat you so that you can exercise, which slows the disease progression down, as we were saying. So I'm going to talk a little bit more about motor fluctuations and then talk about the management of those. And that's something that I have a particular interest in because I do some of the more advanced therapies for Parkinson's in my clinic. So as Parkinson's progresses, the therapeutic window of levodopa narrows, and that's called motor fluctuation. So what that picture is trying to show you, the bottom of that is how long you've had the disease. That's the x-axis, if you remember from high school mathematics. And the top is showing, the y-axis is showing the dopamine level. So what happens is when you take medication, before you take your meds, you have off symptoms. And what I mean by off is that your meds are off. They've worn off, they're not working. And that's when you feel Parkinsonian. And by that, I'm going to resort back to that very first slide where we talked about symptoms of Parkinson's disease. That's when you feel slow, you feel stiff, you're shaky, your voice might be soft, and you're shuffling. That's when your medications are not working. You take your dose of levodopa, the medicine kicks in, you swing up on that curve, and you start to feel better. And that green area in that picture on there is you feeling like your old self before you had Parkinson's. And then, of course, the blood levels rescind, you metabolize the dopamine, the medication wears off, and you go back to your off state. In the early stages of the disease, you stay in that green area of the curve, meaning that you're in a honeymoon period. You take your pills, overall you feel better, you don't notice any dramatic wearing off or kicking in, and you feel pretty good. However, as the disease progresses, the window of that time shortens. And so you may take your medications, and instead of your medicines lasting 6 or 7 hours, now they last 5 hours. And then 1 or 2 years later, they last 4 hours. And what you'll notice is that at the end of that period, you start to feel slow, you wear off, you notice some breakthrough tremor, you take your next dose of medication, and then the cycle continues. And then several years into the disease is when you really might be married to very specific times of having to take your medication. I have patients who, with really severe cases are taking medicine, say, every 2.5, 3 hours at higher doses to try and beat that time to avoid that crash of wearing off significantly. That red portion on that picture there is when the off time is quite significant. And patients with really severe motor fluctuations as they wear off may be unable to walk, may have severe gait freezing or being stuck and slowness. The other feature of this course of the disease as it advances is that at the peak of the dose, patients may have dyskinesia. And dyskinesia are extra dancing movements, kind of like Michael J. Fox, because when I see him, I'm not his physician, I want to be absolutely transparent on that, but oftentimes when you see him presenting on television or at talks, he's moving around on stage like this. And that's actually not really the Parkinson's, that's Parkinson's on medication, because he, I think, is deliberately over-medicating so that he can move freely. That's his personal choice. And so when you see dyskinesia, writhing movements, very different than rhythmic shaking, that is from the Parkinson's brain having that exposure to a levodopa dose, it kind of passing the normal period and actually working so well, or almost too well, that now you're moving excessively and involuntarily. And dyskinesia itself can be troublesome and impairing. It can make people lurch around when they walk, it can intrude on your normal motor function. So dyskinesia can also be impairing. There's such a thing as being over-medicated that can be a problem. And I tend to use, I hope this isn't offensive to anyone, but I tend to use the analogy in my clinic of the Tin Woodman versus the Scarecrow, because the Scarecrow where he's dancing and kind of flopping around, and the Tin Woodman where he's stuck and frozen in his body, and those are your two forms. And when you call your doctor, it's very helpful if you describe what exactly state you're feeling and which one is the impairing, because what we do with the medications, whether we lower or raise them, how frequently give them, is completely going to depend on what history you provide us of these two states. Okay. So when we have the motor fluctuations, the question is, how do we treat these? And so there's lots of different strategies. One is to just escalate the frequency. For example, give the same amount of levodopa closer together. Or do we want to escalate the dose so that when you take it, it's such a big dose that tail end you don't wear off so quickly? And both of those are reasonable scenarios based on the patient. Everything is very individualized and tailored to the patient. We might transition to a longer acting levodopa that's superior to the Sinemet IR or the CR. And that would be this Rytary, which is the capsule with the beads in it. And that actually has been shown to have more steady stream levels of dopamine in the brain and improve motor fluctuations. With the only caveat being it tends to be a bit pricey, unfortunately. We might add adjunct therapy, and that would be getting back to that slide where we add dopamine agonists. We might add things that reduce the metabolism of dopamine. So a very common strategy in Parkinson's, unlike other neurological conditions, is that we tend to use a cocktail of medications. And I know that a lot of people, that's anathema to them. I don't want to be on a lot of meds. I'm very sympathetic to that. But that strategy tends to allow lower doses and more physiologic functioning instead of big pulsatile doses of one drug. So a cocktail allows us to avoid side effects and to try and have a more physiologic state. And finally, we might add amantadine, which is that dirty drug or mixed mechanism drug that actually is extremely helpful at improving dyskinesia. So then, when medication management fails, the next strategy is to use deep brain stimulation. Deep brain stimulation, I like to tell my patients, is a brain pacemaker. What it is that it's a battery placed in the chest, which you can see on that picture there, and a wire that goes under the skin through a hole in the skull, and the wire is placed in the brain. Believe it or not, this sounds, a lot of people are saying this sounds like, Frankenstein. I don't want to be an experiment. I've pretty much heard everything in my office. I want to tell you that we've been doing this since, I believe the FDA approval is 2002. So we've been doing this a long time, and we have a lot of great data on several 100,000 patients that this works. So the brain is an electrical organ as well as a chemical one. It's kind of like your heart. So you know how you can take blood pressure medicine, but you can also have a pacemaker. You can shock the heart if it goes into, VTAC. The same thing is happening with your brain. You can treat it with drugs, which are all the drugs that I just showed you previously, but you can also treat it with electrical stimulation. It has a similar effect. And what we do is, by placing that wire, that current, into a very precise targeted area of the brain, that we stimulate the brain and we override abnormal firing patterns that are created by this disease. Those abnormal firing patterns are also suppressed with medication, which is why medication works, such as levodopa. But the stimulator is a way of having that current going 24/7 all the time, so that instead of you having to take medications every 2 to 3 hours, you can just have the stimulator on at all times and take a lower dose of medication. With the idea that DBS improves your on time, it reduces your troublesome dyskinesia time, and it's on all the time. It also allows medication reduction of 30 to 50% according to the trials. The indications for this, some of you then might ask, I have patients who come in saying, I don't want to take meds. I just sign me up for the DBS. Like, I don't want to, I'm tired of taking all this medication. And again, very sympathetic, but that's actually, that's not what a reputable surgeon will do. It's indicated for advanced disease when best medical management has failed, when there's motor fluctuations and we need some sort of device to provide continuous stimulation. It's done for tremor. It's better at treating tremor than medications. And those patients who absolutely cannot tolerate levodopa. I have patients who either when they take dopamine agonists or levodopa are vomiting. We've seen that even on one pill. And for those, we might have to consider electrical stimulation. There's something called a Duopa intestinal infusion pump. Again, this is for advanced disease. And this is a pump which is placed through a tube, that's through a surgical implant of a tube that goes through the stomach and into the small intestine, an area called the jejunum, and that's what that picture is showing. And that pump is not to scale. Just want to tell you, it's just kind of blown up so you can see it, but you do not have a pump that's the size of your entire abdomen strapped to you. I just want to reassure you. But we do have samples. We have kits in the office, and we can show you guys. There's also a website if you want to see it. This is run by a company. It's called Duopa is the trade name for it. And what it does is every minute it's fusing dopamine in through the gut, bypassing the stomach, which can have delayed gastric emptying, particularly in Parkinson's, and then it goes right to the small intestine and it's absorbed. And it's a way of getting very frequent tiny doses of levodopa to avoid motor fluctuations. It tends to be used in patients who either they can't get DBS, we don't do DBS in people who have significant cognitive impairment, or maybe they're averse to the idea of a brain surgery or so forth. But that's who we tend to do this on. We tend to put people on a vitamin cocktail, a vitamin B complex cocktail. There have been incidences of neuropathy, and side effects tend to be things like tube kinking mechanical issues with the pump, where it can, the tube can kink, or it can go in, or it can be abrasive, and rarely it can get infected. There's something called MRI-guided focused ultrasound, or FUSA, and this has been in the news a lot. I get a lot of questions from this in the office. So I call it FUSA because I was at Ohio State before Brigham. We called it FUSA. At Brigham, we call it FUS. So, so what it is ultrasound energy or sound waves that are beamed very precisely in a surgical suite by a neurosurgeon who's very experienced at this technique using a special machine. And that picture in the bottom right is actually my Ohio State team. I couldn't find a picture from the Brigham team. And that's actually during an actual procedure. I don't have a picture of me in the room. The picture on the upper right, I think, is from University of Virginia. But what we're doing is we're beaming the sound waves, very high energy and precisely, and they heat up the brain through vibration, and they actually, to speak graphically, they melt a tiny area of brain and they destroy it. And that tiny area of brain in the thalamus is a node for a circuit that manages tremor. And by obliterating that, people have less tremor, up to 70 to 90% less tremor. Now, this is not invasive. There's no incision or placement of a wire or DBS thing. But it is done. There are surgical risks, which I'm not going to go too much into that. I want time for Dr. Hung to speak. But this is something that we definitely offer. I want to clarify that there's a difference between this and DBS, because many of you may be saying, well, why would I get an implant if I could just have focused ultrasound and have an ablation, but not have all this stuff put into my head? And that's a very reasonable question. But focused ultrasound only treats tremor. It does not treat slowness or stiffness, whereas the DBS wire, by putting that implant into a different area of brain, treats all the features of Parkinsonism, by that, the motor features of Parkinsonism. This is only used for tremor. So now I'm going to go into the non-motor symptoms of Parkinson's before I hand over the podium. And so this picture, this is courtesy of Temple Health. And this is showing the iceberg. This is a very common pictorial that's used in Parkinson's disease. And above the iceberg, you can see that's kind of what people see. That's what you look like when you're walking around and you may be shaking, and people might see that you're walking a little more slowly, your voice is soft, your lack of facial expression. But what people don't see are all the other symptoms which could be equally impairing, and like the constipation, psychiatric manifestations, depression, anxiety, bladder dysfunction, and so forth. And they are very relevant and worthy of discussion in the office. So urinary, I'm only going to talk about a subset of these for time. So urinary dysfunction, the most frequent manifestation of this in Parkinson's disease is urgency, frequency, nocturia, which is a fancy way of saying getting up in the middle of the night to use the restroom. There's a picture there of the overactive bladder. In other words, a typical bladder, when it feels full, is when it has, the bladder fills up with urine, and then the bladder says, hey, you need to go pee. And then you start having some, feeling of contraction or feeling this urge to void, and you go. An overactive bladder's only, there's this feeling of this urgency and this very frequency, because bladder isn't really at the state. It's prematurely telling you need to void, and quite urgently. So we do have medications to treat this, which include miragibron. Miragibron is, our goal is to have you having a bowel movement every other day. Orthostatic hypotension is sudden drops in blood pressure with standing, leading to lightheadedness. We have some therapies. First line would be fludrocortisone, which is taken once daily or twice daily at most. Midodrine, which bumps up the blood pressure. And then a newer medication called droxidopa, which is quite efficient, where there's you take this 3 times daily to bump up blood pressure. Of course, the first step for people who have orthostatic hypotension, that can be a feature of the disease or also a side effect of levodopa. Oftentimes, you can just lower your blood pressure medications with the onset of this disease and then treatment with dopaminergic medications. So we first peel back your hypertensive medications, and then if this still is an issue, we actually give you these medicines on that screen to bump up your blood pressures, because passing out is actually quite significant. You can break a hip, hit your head. These are all, this is a big deal. This is definitely something that we should aggressively treat. Sleep disorder is very common in Parkinson's. REM sleep behavior disorder is active dreaming. We treat that with melatonin, bed safety, such as locking the windows, making sure any weapons in the house are locked away, blocking the pathway to the stairs, locking the front door. Antidepressants can actually aggravate this. And then when those fail, clonazepam, which is a tranquilizer, not because we think you're anxious or you have insomnia, but it actually is a treatment for this stage of sleep in which this happens, and it can suppress these movements. Restless leg syndrome, very common in Parkinson's. It's an aching, burning, or creepy crawly feeling in the legs that's uncomfortable, relieved by getting up and walking around. Medications of gabapentin and pregabalin are now first choice. Also, we can use dopamine agonists, and we look for iron deficiency. And I believe this is my last slide, the psychosis. So as the disease progresses, in later stages of Parkinson's, we can see psychosis develop, and by that I mean hallucinations, some funny thinking where maybe people become very paranoid or very angry or agitated. There's a medication called Nuplazid, which is pimavanserin, which definitely in trials have shown benefits. Quetiapine is very commonly used because it's not particularly expensive, it's easy to get, pretty well tolerated, and it's cheap. But we don't have a lot of good trial data showing its use, but it's probably the most commonly used drug for this. I'll tell you that these are both antipsychotics, and oftentimes a question that I get in the clinic is, do you know that antipsychotics can worsen Parkinsonism? Why are you giving me this drug? And I'll tell you that these are the gentler of the antipsychotics. They have the least blockade of dopamine. They're the least likely to worsen your disease. And we certainly have to treat the psychosis. And I would rather co-give you something of this. By co-giving, I mean give it along with the levodopa and enable you to keep moving with that levodopa, and then co-administer a medication like this to block the psychosis, then lower the levodopa, and potentially risk worsening motor function, and of course decreased exercise, which is going to slow your disease down. All of these, there's a final medication called clozapine. I've never seen this drug fail. It's a great drug, but it has the caveat of it can have very rare but very serious effects on bone marrow and cause neutropenia or something called agranulocytosis or lack of white blood cells. All of these, we do serial EKGs to make sure that we're not setting you up for any potential arrhythmias, so forth. And finally, cognitive impairment. Unfortunately, a significant percentage of patients do go on to get cognitive impairment. I wish this weren't the case. So we do have some treatments for this. I think this is going to be one of the questions that comes up. And they tend to be the same toolbox, frankly, that we use for a lot of other disorders with memory loss or cognitive impairment. Generally, we use drugs that promote acetylcholine. That's a brain chemical that's been associated with improved thinking, to put it simply. Aricept is a very common one. It has very conflicting results in the cognitive impairment of Parkinson's. Ribostigmine has been shown to be useful in trials. Galantamine, not so much, not great data, so we tend to use ribostigmine or Exelon. Memantine is an NMDA antagonist, a different mechanism of drug. Very little evidence it works in Parkinson's, but we will throw that on there to try to help folks out. It's a medication that they use in other forms of dementia, such as Alzheimer's. There are some research studies that are looking at transcranial magnetic stem. It's a way of kind of stimulating the brain with these magnetic fields, with wands held outside the skull. That's not something that I'm all too familiar with. We have a specialist at Brigham, and I'm sure at MGH who's doing these kinds of things. And there's a question about whether that may help improve cognition or delay its worsening, but these are research studies. This is not a typical mode of therapy at this time. So I want to say thank you. That's the group over at Brigham, and you'll see that Albert was in there, but unfortunately he is now mainly at Mass General, so we would love to have him come back. And that's the address if anybody wants to see us here. And that's it. Thank you so much for your attention.
Great. Thanks very much. My name's Albert Hung. I am a neurologist at Mass General Hospital. It's a pleasure to have the opportunity to speak with you today, and really grateful to the McCourt Foundation for including Parkinson's disease in the Neurological Symposium this year. As all of you know, Parkinson's disease is becoming more and more of a public health problem. Parkinson's is the second most common neurodegenerative condition behind Alzheimer's. And I think a way underestimate is that more than 1 million people in the United States have Parkinson's now. And as the population ages, we're seeing more and more of it. Now, one of the most exciting advances these days actually was something that was passed by Congress and President Biden. Just a couple of months ago, he signed the National Plan to End Parkinson's Act into law. And this act is designed to do a few things for those of us who care about Parkinson's. It's intended to dramatically increase the amount of federal research funding with the goal to develop more effective pathways for treatments and cures. We need to do better in terms of improving early diagnosis and to spark new and improved models for how we can care for people with Parkinson's. And we also want to address health disparities in diagnosis, treatment, and clinical trial participation. And so a lot of this mission really falls in line with what the McCourt Foundation wants to do and what we at Mass General Brigham also want to do. So some of these slides you have already seen from Dr. Changizi's presentation. When we want to make a diagnosis of Parkinsonism, we're looking for a few core features, of which the most important is the bradykinesia or slowness that you talked about. Some people have stiffness, some people have tremor. Most people identify tremor as being the main symptom of Parkinson's disease, but you don't have to have tremor to have Parkinson's disease. And many people with Parkinsonism or Parkinson's disease at some point will start to develop some problems with walking and balance. Now, what we also know about Parkinson's disease is something that you saw earlier. We know biochemically what are the cause of the motor symptoms of Parkinson's disease, and that is the loss of dopamine-producing neurons in that black part of the brain, the substantia nigra. You know, the consequence of this is that people with Parkinson's disease don't have enough dopamine in the brain. But as you already heard from Dr. Changizi, This process starts long before a person develops the first signs of tremor, stiffness, or slowness. There's some data from pathology studies that suggest that by the time a person develops any symptoms of Parkinson's, about 75% of those dopamine-producing brain cells are already gone. When we focus down on that part of the brain with a microscope, you see these pink structures in the brain cells. These are what are called Lewy bodies. And Lewy bodies are abnormal protein aggregates that live in the neurons of those brain cells that are affected. And when a pathologist wants to make a definite diagnosis of Parkinson's disease, they need to look down at the brain under a microscope and look for the presence of these Lewy bodies. So you've already seen this analogy to the iceberg. When people come into our office as a Parkinson's specialist, they're coming in because they notice some change in their movement or because their family or their primary care doctor noticed a new tremor. But that part of the brain, the substantia nigra, is only what we can see, what's on the surface. There are many other parts of the brain that are also affected by Parkinson's, and as a result, you get a variety of different symptoms, only a small percentage of which are those motor symptoms. Now, this leads to an obvious problem and an obvious question in the way that we diagnose Parkinson's. If we are diagnosing Parkinson's on the basis of these motor symptoms, and if it takes loss of 75% of those brain cells before we can make a diagnosis, we're missing something because we're trying to diagnose Parkinson's based on clinical symptoms rather than the biology of what's happening in the brain. So this is a schematic of what happens in Parkinson's disease. So the second half, beginning from time point 0, is when a person has Parkinson's symptoms. So you first start to develop some of the motor symptoms, the tremor, the bradykinesia, the rigidity that allow us as a clinician to make a diagnosis. By that point, people already may be experiencing some of the non-motor symptoms, and as the disease progresses, some of those later symptoms, the psychosis or the cognitive impairment that you heard about, start to develop. But the problem is that Parkinson's didn't start there. Parkinson's began probably years or decades, even before that first tremor or before that first hint of stiffness or slowness appeared. Some of the non-motor symptoms that are particularly useful in early diagnosis are the REM sleep behavior disorder that you heard about, the acting out of dreams, and also loss of smell, or what we call hyposmia. And these two particular non-motor symptoms are very helpful in terms of identifying who might be at risk to develop the motor symptoms of Parkinson's. And this can happen years or even a decade or more before the diagnosis of Parkinson's is made. So the question is, how do we identify these people? Because if we really want to make a difference in slowing down Parkinson's, we need to be able to intervene before people are as far along in the development of Parkinson's as they are by the time they come to clinical diagnosis. One of the genes and proteins that seems to play a critical role in the development of Parkinson's is called alpha-synuclein. We have now known about alpha-synuclein for about 25 years. And the first hint that alpha-synuclein might be relevant to the development of Parkinson's is that there are a very small number of families where there's a genetic mutation in the gene that codes this alpha-synuclein protein. And that mutation in and of itself can cause a person to have Parkinson's disease, and that runs in families. There's also a few families that have normal alpha-synuclein genes, but have an extra copy. So all of us have 2 copies of every gene. Some people had 3 or 4 copies of this alpha-synuclein gene, and that, again, in and of itself, is enough to cause Parkinson's disease. And we know that other genetic changes in and around the synuclein gene that affect the amount that's made in your body also are risk factors for developing Parkinson's. And so having too much alpha-synuclein or the wrong type of alpha-synuclein by itself can cause Parkinson's. It also turns out that those Lewy bodies that I mentioned, what are the pathologic signature of Parkinson's disease, are primarily made up of alpha-synuclein. And what years of research has gone to show is that those alpha-synuclein aggregates can develop in parts of the nervous system outside the brain, outside the substantia nigra. And it's the gradual propagation of those abnormal alpha-synuclein aggregates that seem to cause Parkinson's disease. So what can we do to try to diagnose Parkinson's earlier? Well, there's a few tests that we can use now that help to support or allow for early diagnosis of a synucleinopathy. One of them is a type of scan called a DAT scan. DAT scans look at dopamine activity in the brain. And so people who have Parkinson's disease, you would expect to have less dopamine and less uptake on this. You can see the picture on the right where the normal scan has these two comma-shaped structures, and somebody who has Parkinson's disease, you lose part of that. There's decreased dopamine activity. One of the biggest breakthroughs within the last 3 to 5 years in Parkinson's disease has been the ability to detect abnormal alpha-synuclein earlier. Now, this is brand new, but we can now pick up abnormal alpha-synuclein deposits in nerve cells in the skin. So if you do a skin biopsy, you can find some of this abnormal alpha-synuclein, and that is a predictor that the same type of process might be going on in the brain. There's another type of test now that's available, which is called an alpha-synuclein seed amplification assay. Now that's a long term that basically refers to the fact that you can find some of these alpha-synuclein aggregates floating around in the spinal fluid of people who have Parkinson's disease. And if you collect some of the spinal fluid and shake it in a test tube with normal alpha-synuclein, it forms aggregates. And so these aggregates can be picked up with a particular marker. One of the biggest breakthroughs in the last couple of years is that you can pick up these alpha-synuclein aggregates in people who do not have Parkinson's disease diagnosed clinically. So if a person has REM sleep behavior disorder, or if they have REM sleep behavior disorder and loss of smell, these prodromal features of Parkinson's, you can already identify abnormal alpha-synuclein even if a person can't be diagnosed with Parkinson's. And so what we're coming to is, rather than making Parkinson's disease a clinical diagnosis based on those motor features, these advances help us to diagnose Parkinson's biologically based on what's going on in the brain and in the body. And hopefully these advances allow us to make a diagnosis at a much earlier stage. Another hot area of research for Parkinson's these days is the role of genetics. Now, many people will ask when they come to the office, is this something that I'm going to pass down to my family? And for most people, the answer is no. So genetics probably only accounts for about 10 to 15% of Parkinson's cases. There are certain ethnic groups, the Ashkenazi Jewish population, North African Berbers, where there's a higher incidence, maybe more, about 30 to 40%. And this is a list of some of the genes that have been associated with causing genetic forms of Parkinson's. I already mentioned alpha-synuclein. That's a very rare cause, but there's a couple of other ones, one that's called GBA, or glucocerebrosidase. This is a gene when a person has 2 abnormal copies, gives rise to a very rare condition called Gaucher's disease. But if you have 1 abnormal copy of the GBA gene, that increases your risk for Parkinson's. There's another gene that's called LRRK2. And GBA mutations, LRRK2 and alpha-synuclein, give rise to autosomal dominant disorders, meaning if you have 1 abnormal copy of those genes, that by itself increases your risk for developing Parkinson's. And there's a large study that's going on that's funded by the Parkinson's Foundation called PD Generation that offers free genetic testing for these 7 genes for anyone with Parkinson's disease, because the idea is, if you know that you have a genetic cause that might affect the way that you think about your disease, about how it affects your family, and then most importantly, as I'm going to get to in a minute, how you think about participation in clinical research trials. So this is a schematic for the way that we start to think about Parkinson's. It's probably a combination of genetics as well as some environmental factors that come together to cause changes in alpha-synuclein. When alpha-synuclein deposits abnormally, you get Lewy bodies in the brain that causes degeneration of those dopamine-producing brain cells, and as a result, you get Parkinson's disease, both what you see on the surface as far as the motor symptoms and that what's hidden underneath the non-motor symptoms. So We've known a lot about Parkinson's disease for decades. We've known about alpha-synuclein for about 25 years. A question that comes up is, why don't we have anything yet to slow down the progression of Parkinson's? Why have disease-modifying trials failed? It's not because of lack of effort. It's not because of lack of investment. Here are some of the reasons. One is we don't have great animal models for Parkinson's disease. We can induce a type of Parkinsonism in animals using some toxins or with genetic manipulation, but those don't really reflect what happens in people. One of the challenges that I already mentioned is early diagnosis. If a person has already had changes in the body that lead to Parkinson's for 5 or 10 years by the time they come to diagnosis, maybe that's already too late to intervene. Parkinson's, even though we think of it as being one condition, is really quite heterogeneous. Some people have a lot of tremor, some people have more problems with stiffness and slowness, some people have early cognitive changes. And so when we include everybody into a clinical research trial, that heterogeneity of disease might swamp out some changes where maybe a particular subgroup of people with Parkinson's might respond to whatever treatment we're trying. Up until recently, we really haven't had any biomarkers like the synuclein amplification assay to modulate disease progression. And so if we're relying on our clinical assessments, that's very coarse and unrefined, and we might miss small differences. And then the last reason, which is both positive and negative, is that Parkinson's progresses very slowly. It doesn't progress over weeks or months. It progresses over years and decades. And so in order to find a disease-modifying treatment, we might need to follow people for 2, 3, 5, 10 years or more. And these types of clinical research studies are really difficult to do. So I'm just going to close by just giving you a taste of a little bit of some of the approaches that are being used to target disease modification now. One approach is targeting alpha-synuclein directly. And the reason why this makes sense is we know that this is a critical step in the development of Parkinson's. So if we can figure out a way to decrease the amount of alpha-synuclein, break up some of the aggregates, prevent some of those aggregates from spreading, that makes biological sense. One of the challenges, though, is maybe by the time we intervene on alpha-synuclein, it's already too late. Maybe the process has already been triggered, and maybe by the time we're able to try something new, the process is too far along. Another approach is to use genetic targets. The advantage of targeting a genetic cause is we know for those people who have a genetic mutation what the pathway is that seems to be causing the Parkinson's. And so if you were to limit a clinical trial to those people who had a particular genetic mutation, say in GBA or LRRK2, the likelihood is that with a more homogeneous population, we might actually find something that works. The problem here is there aren't that many of those people around, and so it might be hard to recruit people and to do a large enough study to be able to see a difference. And then it raises the question, for the majority of people who don't have genetic Parkinson's, if we find something with these types of treatments, are they relevant? Then the last approach is to use repurposed drugs, and by that what I mean is using medications that have been approved for other conditions, and because of shared mechanisms in the way that they work in the brain, trying to figure out whether they might have a benefit in terms of slowing down Parkinson's. Now, the advantage of those approaches is that oftentimes we already know what their safety or side effect profile is because they've been studied in other medical conditions. And if they do have benefit, we can fast track the approval for the FDA because they're already available. You can already get them at a pharmacy. The downside of that is if we're using medications that treat multiple medical conditions, how specific is it for Parkinson's? Maybe that doesn't matter, but we do want to make sure that it's going to have a benefit for the people that we are going to try to treat with it. So when we're targeting alpha-synuclein, there are different steps we can target. We can reduce the production, we can block the aggregation, we can speed up the degradation, we can block the propagation, or we can try an immunologic approach where we basically recruit a person's own immune system to try to help get rid of alpha-synuclein. And all of these are in clinical development right now. When we're thinking about clinical trials that target genetic Parkinson's, there are currently GBA-targeted and LRRK2-targeted treatments that are already in development. There are already a number of alpha-synuclein targeted treatments that are in development. And so our hope is that these studies will shed some light on the development of Parkinson's in particular populations, and maybe that will extend in terms of having some disease-modifying or neuroprotective effects for people who don't have these genetic mutations. As far as drug repurposing, the medication class that has gotten the most attention are the GLP-1 receptor agonists. These are medicines like Ozempic. Now, Ozempic seems to be the cure-all for everything. You know, it's available for obesity, it's available for diabetes. I saw a press release recently that says it might help slow or protect people from cancer. But there was a study that was published now about 4 or 5 months ago that an Ozempic-like drug slowed the progression of Parkinson's. Now, how does diabetes, obesity, and these GLP-1 receptor agonists pertain to Parkinson's? Well, it turns out that people with type 2 diabetes have an increased risk of Parkinson's disease. And there is an association between this aggregation of alpha-synuclein in the brain and insulin resistance, which is what causes type 2 diabetes. When you look at studies that have treated people with diabetes with a variety of different classes of medications, those who were treated with the GLP-1 receptor agonists seem to have a lower risk of developing Parkinson's disease. And we know from animal studies that GLP-1 agonists reduce brain inflammation, protect dopamine cells, and help in terms of reducing the amount of alpha-synuclein. And if you give an animal who has an animal model of Parkinson's with this class of medications, you can protect the brain. So it's a very, very exciting area, but we'll have to see. So the one study that generated so much attention was the use of a medication called lixisenatide. This is one of these Ozempic-like drugs that's not available in the US, but is available in the UK. And they gave people injections of this medication for a year. And those people who were given the active medication seemed that their symptoms did not progress, and those who got a placebo had progression along the lines of what we might expect for somebody with Parkinson's. And if you washed out the medication, the people who were given the active medication were still doing better. Now, this drug is not without side effects of its own, and so many people who are given the drug develop significant nausea and vomiting in a way that people on placebo weren't. So my goal here isn't to really go over all of the details, but just to give you a flavor for some of the active areas of research that are going on now with the goal to slow down Parkinson's. The other important change that everyone with Parkinson's, really everybody should make in their lifestyle, is to exercise. Dr. Changizi mentioned this a little bit, but in particular for Parkinson's disease, in these animal models, it looks like exercise itself can actually protect the brain. There's a large NIH-funded study going on right now called SPARKS-3, where people with Parkinson's not on medications are being randomized to doing moderate or high-intensity exercise. They're not randomized to placebo because we don't want to discourage anybody from doing exercise. But the goal is to see whether or not differing amounts of exercise will protect the brain based on measurements from the DAT scans that I talked about, as well as in terms of clinical symptoms. And there's a large study going on that's originally started in the Netherlands called Slow Speed, where they're actually taking people who don't have Parkinson's but have this REM sleep behavior disorder, which often comes on before the Parkinson's, and seeing if you can encourage people to do more exercise through a smartphone app. Will that change or alter the rate of those people who are already experiencing REM sleep behavior disorder? Will it change the likelihood that they convert and develop Parkinson's symptoms? So just to summarize, Parkinson's disease is characterized by the abnormal aggregation of alpha-synuclein and degeneration of dopamine neurons. And it's those two biological factors that are changing the way we think about a diagnosis of Parkinson's. Hopefully, those advances will allow us to diagnose Parkinson's earlier, and so we can find people who may be at risk for developing Parkinson's and enrolling them in these disease-modifying trials. There's many active trials that are going on right now, and the hope is that one of them will yield some fruit at the end of the study. And for everybody, you should consider exercise as a modifiable protective treatment for Parkinson's. So the way that we think about this is that as a Parkinson's community, we're taking many shots. The more shots at the target we take, the more likely we are that one of them is going to hit the bullseye, and that's what we're all looking for. And I guess the lesson I would take, hold on to hope. I think Parkinson's, we know, is not a condition that's easy to live with. I think that all of the treatments that Dr. Changizi discussed give us good opportunities to try to improve symptoms and improve quality of life, while at the same time there's a lot of research going on to try to find that holy grail, that way to slow down Parkinson's. So thanks very much for your attention. Anybody who has a question should just raise your hand and somebody will come around to you with a mic. And I know we're also fielding some questions from the virtual audience, and so feel free to send any questions our way. Dr. Changizi and I would be happy to answer them.
Hi, it's me again. This has just been a great conference. Thank you so much, and I say this to a lot of people. You could have done anything in your life, but you chose to do this, so thank you so much, and fabulous. So I can honestly say, I always knew maybe environmental as well, and hand to God, there's 5 people I know who have it. One was a fireman. I think 9/11 is going to be even bigger. Another dear friend of mine who I worked with for years, really nice guy. He was in the height of Vietnam when Agent Orange was going on. So these all people have Parkinson's. Another friend of mine is Jewish, and he said, absolutely, which I didn't realize that certain ethnicities, whatever that word is, I can never say it, it's just like anything else. So that's great. And what was the other one? Oh, another friend of a friend who's married. This guy's worked construction his whole life. So absolutely. So, thank goodness you've kind of putting those pieces together. And I often wondered, why is this not in children and, young adults? It seems to me, maybe I'm mistaken, that it's only in an elderly population, like 65 and above. Although Michael, what's his name? The actor, but he seems to be kind of that. So I just kind of want to know, is that your experience? Oh, Michael J. Fox, there he goes. Thanks for that whisper. So that's it for me, and thanks again. This has been fabulous. Where'd you go?
We also had a piggyback on that question from our virtual audience. They said that their father, who is 77 years old, worked with pesticides for a good portion of his life and was wondering if that might have had exposure to the pesticides might have anything to do with his diagnosis.
So those are really great questions, and I think it highlights the challenge in terms of trying to get at a cure. There are probably different causes for different people. I think that as far as environmental toxins, pesticides, I think, is one of the areas which has gotten the most focus, and we can generate animal models of Parkinson's by exposing them to particular pesticides like rotenone. So, it's hard to know how much pesticide exposure is enough. Is your weekend gardener who uses a little bit of pesticide, is that enough, or does it have to be somebody who's spraying crops or somebody who served in the armed services in place where they use pesticides? So we don't really know the answer to that question, but I think we're starting to learn more about how different factors play a role. To the question about the genetics and the age of onset, so you're right, most people with Parkinson's disease develop Parkinson's later in life. Average age of onset is somewhere around the age of 60 to 65, but there are about 5 to 10% of people who develop Parkinson's before the age of 50 or even 40. It's what we call young onset Parkinson's disease. And what we don't entirely know is that a different type of Parkinson's. Do those people who have young onset Parkinson's are more likely to have a genetic cause, but not all of them have a genetic cause. And so I think as we're trying to think about better ways to understand Parkinson's and to do research, we have to recognize that different people with Parkinson's are ending up with the same types of symptoms coming from very different directions. Dr. Changizi, maybe you can take this question that was submitted before. So what are your thoughts regarding the use of psilocybin, marijuana, or other hallucinogenic methods as a treatment or symptom suppression for Parkinson's?
Okay, so that's something that I would say, again, I'm asked pretty much every clinic day. Somebody wants to learn about marijuana. And so here would be my take. I think that there is very interesting biology behind cannabis. There's definitely, there's studies that show receptors for cannabis are in the basal ganglia. That's that set of structures deep in the brain. And so there is likely some modality where this class of medications has an effect, possibly beneficial. The issue is that there are, I believe there's about 4 randomized clinical trials. And by that I mean trials where they look at patients who are given placebo or a sugar pill and then some sort of, cannabis in some sort of form. And those are very different according to the studies in terms of the dose and how they were administered. And then they look at the output of whether patients improve. And that could be motor scores. Do they feel better? Are they less depressed? Are they less anxious? And so forth. And 3 of those studies out of the 4 showed no benefit. So I really want to emphasize that we really have very poor data suggesting in a controlled, research coordinated way that this shows benefit. But there's a possibility it can help. And I think what's happening is there's a lot of anecdotal evidence. There's a lot of, we now have YouTube and videos and the internet showing specific instances of patients using these substances or talking about their personal stories. And I think that they're being truthful. I think they're sharing their personal experience. I don't think anyone's making this up and so forth. But these things are not controlled. We don't know the dose. We don't have the way that this is being given. We don't have somebody blinded to the participation. We don't know what other things that individual did that day that may or may not be helping them. And so right now, at least my framework, and Albert can comment on what he talks to, how he mentions this to his patients, I say I don't advise this. I think that we need more data. It could be that in the future, there are some very interesting results from this class of remedies. But right now, I can't tell you how to take it. I do not have supportive evidence to show that this works. We have other modalities that are better at treating these symptoms than this. And I also just want to introduce this element, and this might be unpopular. I think there's a lot of pushing of this. There's a lot of industry support behind making this a panacea of treatment. It's now being legalized in states. I have no opinion on that, but there is a market for these drugs. And I think that there's a lot of push to sort of show that these things might help and so forth. And the data is not catching up to the push that these might help. So I would be careful. I think there's better ways to treat these things, but I think that there's some very interesting ideas that might come out in the future. I hope that's fair. That's about the cannabis. About the, and I always forget the name of it, but the mushroom-like entity, the psychedelic, psilocybin, I want to say is maybe the name. That, again, there's some interesting data about depression, but not really bearing out specifically to Parkinson's disease. Also some question about whether these medications or these drugs, they may target neuroprotection. They might help that. Again, poor evidence. So this is not something that I would advise. We have better agents out there. I think that we need to let the research continue. A large predominance of the, for psychedelic research, at least my understanding, and Albert can correct if I'm wrong, is on animal studies, not humans. There's really a paucity of data to support its use in neuroprotection in Parkinson's. So I personally would advise my patients to stay away. Let's get more data and see what happens.
I would agree with that. I think one of the biggest challenges as we're trying to do research to come up with cures for these diseases is that there's a lot of anecdotal evidence. There's a lot of information out there about medicines, supplements, recreational drugs that might have some benefit. The only way we're really going to figure out whether these really help is to do it in a systematic way. That's probably going to be one of the biggest barriers in terms of us understanding how cannabis works for not only Parkinson's, but other conditions. Nobody wants to be in a placebo-controlled study of cannabis. If you're interested in it, you're just going to go get it, right? So the problem is we're never going to get that data, and so we're never going to be able to give sort of evidence-based guidance on how to use these. Anybody else have a question here or any other online? Otherwise, we can go to some of the questions that were submitted before.
And don't be shy. Probably anything you're thinking is the person next to you is also wondering, and they might be shy to ask. So feel free to, there's no silly questions. Please ask away.
Well, my question is, there is no research to diagnose early right now. And if there is, are they thinking about some way to diagnose the disease early before? Because you're saying by the time you see people with tremors, it's already 75 or 50 to 75% already damaged, right? So there's no research to diagnose it early?
Well, so there is research to diagnose it earlier, and I think some of the tests that I mentioned, like this spinal fluid test, this is a way that you can predict who may be at risk for developing Parkinson's. And there's actually a lot of research to extend that to a blood test now. So if you can draw some blood from someone, look for aggregates of alpha-synuclein, that might predict who's going to be at risk. The question is, how are we going to use that clinically? When you go in for your annual checkup with your primary care doctor, in addition to checking for your blood pressure, checking for diabetes, is your doctor going to send off a blood test to say that you're at risk for Parkinson's or you're at risk for Alzheimer's? For those of you who were in the previous session, you probably heard about some of the advances in blood biomarkers for Alzheimer's. It's a tricky question because having a blood test and saying that you might be at risk to develop Alzheimer's or Parkinson's in 5 years or 10 years or 15 years or 20 years, when you don't have that condition yet, you can kind of think about, well, how would that change my life? Would that be a positive or is that going to be a negative? And I don't know the answer to that question. And I think that answer is going to be different for each person. So I think the short answer is that we are making advances in terms of trying to make a pre-symptomatic or a preclinical diagnosis of Parkinson's. For those of us here in the audience, we would probably want to know. But if you go out to your general audience and say, well, if you were going to develop Parkinson's in 15 years, would you want to know? I think if the answer were that we had a medicine to slow it down, everybody would say yes. If you didn't have a medicine to slow it down, maybe the answer is a little bit nuanced and a little bit less clear.
And I just want to add to that, that's very eloquent, Albert, is that I do think they're changing. Albert alluded to this in the talk. The field is making dramatic changes in how we see this. So this year, 2 classification schemes for diagnosing Parkinson's that are not based on the motor symptoms of Parkinson's were published. And this is actually a very hot topic in our field. And those criteria for the new diagnosis of synucleinopathy or Parkinsonian type syndrome are actually not really dependent on the motor features of Parkinson's any longer. They're capturing the constipation, the active dreaming, the lack of smell, biomarkers that Dr. Hong mentioned. So those, or genetics and imaging studies. So all of the surrounding features, which are biomarkers and prodromal signs and genetics, are a far more predominant role in what some people now want to diagnose as Parkinson's disease rather than the motor symptoms that come later. And it's a big hot topic, and there's a lot of disagreements. A consensus statement came out from our Movement Disorder Society talking about just the ramifications of, we need to be careful because, do we know that there's these prodromal signs in everybody? Do we know that everyone's going to go on to get Parkinson's? There's different ways of displaying this disease. Not everyone has the genetics. We need to be absolutely careful about how we're talking about diagnosing a disease that has no cure, not really a lot to prevent it, and may be persisting for decades before motor symptoms are clear. But definitely this idea that you're mentioning of why aren't we diagnosing this earlier? Why don't we tell people earlier they might have this? And that exactly is a topic of discussion. And 2 major papers came out this year just on categorizing Parkinson's with exactly that question.
We've gotten a few questions from the virtual participants regarding both exercise and paying attention to gut health as being something they hear over and over to maybe having benefits for Parkinson's. And they just asked if you could comment specifically how each of those things actually help.
I'll talk about exercise. How's that? So I think exercise is, the more you do, exercise really helps everything. And that's a really vague global statement, but I'm just going to say that if there's one thing that you take away from today, it's to just get out there. And I realize that for some of you, it's tough. There's programs like Sit and Be Fit. But just anything. Humans are meant to be active, and exercise can delay dementia. It can slow the progression of Parkinson's. It can offset depression. The more active you are, all of these things will improve. Everything will get better. So now, are there specific types of exercise that are better than others? I get people saying, well, exactly how much do I have to do? A rule of thumb that I give people is 150 minutes a week. It's like 5 sessions for 30 minutes. But I would say the more active you are, and by that I mean a bit vigorous. I mean that you're a little bit out of breath and that you're pushing yourself. Some of the studies are showing that it has to be a little bit uncomfortable. You're feeling tired as you do it. The other thing that I encourage is from the plasticity element. By that I mean helping your brain to stay mentally active is to do an exercise. Well, first of all, to do something fun so that you actually do it. And the other one is to do something that requires thought. So, again, it doesn't have to be perfect, but anything is better than nothing. But, dancing or doing something where you have to join a class and follow some steps, or you have to think about the move, maybe some Tai Chi or some sort of martial art that's safe, where you're involving not only motor pathways and vigorous and doing a cardiovascular exercise, which is good for protecting the brain, but you're doing something to also encourage that plasticity in the brain of having things kind of reconnect and learning how to fire together, the neurons in the brain to help that active exercise is good. The overall idea is that a healthier brain in general has less inflammation, less cerebrovascular insult, less scarring from things like hypertension, diabetes, cholesterol. A younger brain in general is better to handle an advancing neurodegenerative disease like Parkinson's, and probably helps remodeling and probably suppresses the inflammation that is happening from some sort of genetic and environmental insult in Parkinson's. And so the more active you are, the better you're fighting this. And it gives you something to do. It's unfortunate that you have this disease, but one way of fighting this is to be active. And so that would be my take. Hopefully that's answering that question. Yeah.
Yeah, and then getting to the issue of gut health, I think that some of the questions that are being brought up relate not only to Parkinson's, but to brain health in general. For Parkinson's in particular, there is this idea of a gut-brain axis. Some of those alpha-synuclein aggregates that I mentioned are also present in the nerve cells in the gut. And there's a hypothesis that they might start there and then gradually spread up the nervous system. And that's what causes Parkinson's disease. So, I don't think we really understand about how directly changing or improving gut health affects the development of Parkinson's. People will ask about probiotics and treatments like that. We don't really have the data, again, much along the same line as some of the other treatments that we've been mentioning. But I think that in general, focusing on gut health, one of the questions actually that we got before was, what is the best anti-inflammatory diet? I don't know that there's a specific Parkinson's diet, but I think that there's some evidence to suggest that sort of a Mediterranean diet is good for brain health in general, and I think that probably pertains to Parkinson's as well. Maybe, Kelly, I can ask you one question. A number of issues that have come up was, what about dementia? Are there ways to differentiate or distinguish dementia from Parkinson's, say from Alzheimer's disease? And then where does dementia with Lewy bodies fit into all this?
Okay, that's a great question. So, so dementia, there are unfortunately many ways to be demented. So we have Alzheimer's. You have I believe some of you may have listened to an earlier talk on this, and there is the dementia associated with Parkinsonism. So I'm first going to talk about the differences. But then I'm going to talk that there's quite significant overlap between these two. So the cognitive impairment that comes with Parkinson's disease is called a subcortical impairment. It means that it's happening due to problems with structures deeper in the brain rather than the cortex is one idea. And it tends to involve problems with what's called executive functioning, problems prioritizing, making decisions. There's also some impairment with visuospatial skills, such as trying to figure out how things fit together, drawing shapes. In a practical standpoint, things like figuring out spatial relations, driving a car, backing it down the driveway, and so forth. Those are aspects that are often affected in Parkinsonian-type cognitive impairment. There is Parkinson's disease, which if you have it long enough, there's a substantial proportion of those patients who go on to get cognitive impairment, but not all. That's a controversial question in the field. There's a different disorder called dementia with Lewy bodies, in which patients have simultaneous or very close onset, if not preceding, cognitive impairment at the same time the motor symptoms present, rather than a delayed end-stage progression of the disease. It is controversial in our field about whether these are the same disorders. Some feel that these are just the same. A lot of the changes that you see in pathology on slides of brain cells, they're identical in dementia with Lewy bodies and Parkinson's disease, but they tend to be predominantly different areas of the brain at different stages of the disease. Lewy body dementia is the same thing as dementia with Lewy bodies. I think that was one part of the question. But there's a propensity for early cognitive decline, tends to be around the time of onset of motor symptoms, a much greater, easier, a much lower tendency, threshold to get hallucinations. Hallucinations occur early in the disease and at very lower doses of medication, and then sometimes some altered awareness spells. There's Alzheimer's is a different disorder. It has a different pathology. It has a different type of protein inclusion and a different type of badness or aggregates that are happening in the brain. This is beta amyloid and tau. It is a completely different class of pathology. There's synucleins, which is, getting back to Albert's talk, is the Parkinsonian disorders, and then the tau is the Alzheimer's. The Alzheimer's tends to manifest, and I am not an Alzheimer's expert, there tends to be issues more with memory, with vocabulary, with language. That it tends to have a different way of earlier features going wrong than the Parkinson's. That said, there's a lot of crossover because these are both occurring in populations with aging. Alzheimer's is the most common neurodegenerative disease. Parkinson's is second. And so, when you get to your 70s or 80s, there's chances that you may have both. There's also some implications that the tau, which is the accumulation in Alzheimer's, plays a role in Parkinson's, less so than synuclein. But when we do autopsies of patients with Parkinson's, we see some tau sometimes. And we don't know if that's because they were also going to get Alzheimer's. Is that actually a feature of Parkinson's? So a lot of folks have manifestations of both types of disorders, particularly the older you get. We have, unfortunately, the same class of medications to treat everything when we don't have many. That's the holy grail of medicine. And I'm not going to talk about the more vaccines or things for amyloid and so forth. That's beyond my expertise. I'm a movement disorder specialist. But the medications to help memory, things like Aricept, ribostigmine, memantine or Namenda, we use those in both of those disorders. And generally, we hope those class of medications improve the chemical makeup in the brain in any disorder with cognitive impairments. So we tend to use them for a vast majority of dementia-type disorders, regardless of etiology.
I think we're at time.
Okay.
So thank you for spending the afternoon. Thank you for listening. I think that the work that we're doing to try to cure neurological disease is so important. And, many of our centers here in Boston, supported by groups like the McCourt Foundation, this is really the key towards trying to make advances. So hopefully as you come to these symposia from year to year, we have an opportunity to share big advances and hopefully we'll one day get at that cure. Thanks very much.